Action Plan and past State President Dr. Jose sir, our IAP Kerala State Secretary Dr. Gopi Mohan, IAP Kerala Joint Secretary Dr. Ranjit, the convener for TIPS for House Surgeons Dr. Nisha, other dignitaries like Srinivasan sir, seniors who have joined us today on this platform, and all my dear friends and house surgeons. It's my proud privilege to welcome all of you today to this TIPS series for house surgeons, helping them in their office practice. In fact, this program was envisaged by Jose sir 2 years back by a TIPS series for medical officers in collaboration with KGMOA of the state. And this series has been running very successfully and very popular among house surgeons and medical officers. So I welcome our state president, Dr. Riyaz sir, to today's meeting. Welcome you, sir. Next, I would like to welcome our speaker for the day, Dr. Akbar Sherif sir, who had wholeheartedly and straight away who had agreed to take up this very useful topic for house surgeons. Thank you, sir, and welcome to this day. And next, I would like to welcome our vibrant convener for the Presidential Action Plan, Jose sir, to this meeting. Welcome you, sir. I would like to welcome our energetic office bearers of IAP Kerala, Dr. Binukut and Dr. Ranjit, Dr. Gopi Mohan, to today's webinar. And I would also like to welcome my own convener and the backbone of this program, Dr. Nisha from Kottayam, to this meeting. Last but not the least, I would like to welcome all the participants and all my dear house surgeons to this series today. Over to you, Dr. Nisha. Thank you.
Thank you, sir. Now let me invite our dear President IAP Kerala, Dr. Riyaz sir, for the presidential address.
Thank you, Nisha. So, respected guest faculty for the day, Akbar Sherif sir, the heart and brain of this program, Dr. Joni, the convener, Dr. Nisha, my dear mentor in IAP, Jose sir, my teacher, Srinivasan sir, and all the respected seniors here and my dear students. Actually, IAP Kerala has envisaged this program for the last 2 years, and it has been running successfully over the last so many months. And the real difference is in actually the delivering of the lectures here. Because while you are students, you are actually taught how to write the answers in the examination and how to pass the exam. But here, the faculty will be telling you the practical tips. Today's topic is very, very important because pediatric surgery is not like general surgery. Like we say that child is not a miniature adult. The surgical problems in children are totally different. So we have a very esteemed and very popular faculty in pediatric surgery, and sir will lead you to the clues about how to pick up the cases which need to be referred to a pediatric surgeon. And how to identify them. I wish you happy learning to everyone and let the program continue. Thank you.
Thank you, sir. Now, let me call upon Dr. Jose sir, convener for the Presidential Action Plan for the felicitation.
Thank you, Dr. Nisha. Respected our State President, Dr. Riyaz sir, today the faculty, Dr. Akbar Sherif sir, the State Convener of the Housing Tip Program, the dynamic leader of our IAP Kerala, Dr. Joni, convener, Dr. Nisha, our State Secretary, Dr. Gopi Binukutan, and the senior faculty like Srinivasan sir, and all the Hausians and all the members join here. As Dr. Riaz mentioned and Johnny's mentioned, this for the last 2 years, under the guidance of leadership of Dr. Johnny, this program was conducted throughout the Kerala for last 2 years in a regular manner. And that is all important. Selection of topic is also very important. The very important relevant topic for the tips for how they have to identify the Hausian in a day-to-day practice. And outside, I congratulate Dr. Joni and Nisha for doing a wonderful job under the guidance of Dr. Riaz. And this is actually this is a very flagship program for IAP because we are teaching the students in the undergraduates, but come to practice, they have to be identify the difficult case in a what are the clues in identifying the difficult situation. And today the topic is very important, and abdominal pain and pediatric abdominal pain is very always a nightmare for a medical officer to identify the serious condition. So the Hausian to be identified how to pick up the serious case in at the point of a clinical examination. I think none other than our Akbar Sherif sir is sir. Sir, whether sir is remembering me or not, I am also the student of Akbar Sherif sir in 1994 onwards. And when I joined in anesthesia in Calicut, sir was there. And again, I know the sir is well known, and the pediatric surgeon as well as having a clinical clues, identify the pediatric surgery issues in at the point of examination. I think this program will be very useful for those who are all the seniors who are joined, all the Hausians are joined, will be benefited by the talk by none other than Dr. Akbar Sherif sir. So I think all the best program. Again, congratulate Dr. Riaz, Joni and Nisha for taking this step in a flagship program regularly for the IAP Kerala. Jai Hind, JAP. Over to Dr. Nisha.
Thank you, sir. Now we have our Secretary IAP Kerala, Dr. Gopi Mohan. I invite sir to say a few words.
Thank you, Nisha. Here, faculty of today, Akbar Sherif sir, chairperson for this Johnny, and our convener for Ignite, Joseph, all the seniors and my students. I should thank Johnny and Nisha have really selected a topic which is very much relevant the house surgeon. As this is a tip, it's about how we diagnose and treat, not about theory. And I'm very happy that it has been successfully running here. And I won't take much of the time. I wish this program a success and a happy life.
Thank you, sir. Now we will be proceeding to the academic session. Our speaker for today is Professor Dr. Akbar Sherif. Sir had his MBBS from Kottayam Medical College and had his MS and MCH pediatric surgery from GMC Trivandrum. Sir was a former professor and HOD of pediatric surgery at Calicut Medical College and is now currently working in IGRA Hospital. So sir will be talking on a common vexing problem seen in the emergency, faced in the emergency by every one of us, abdominal pain in children. What to say?
Can you start? Am I audible?
Yes, sir. Yes,
sir,
yes.
yes.
Yeah. Shall I start?
Yes, sir.
Please. Sir.
Good evening, dear friends. At the outset, let me thank the organizers, IAP, for giving me an opportunity to join you for this teaching program. I was telling Johnny, he called me in the afternoon. I was actually sleeping. He asked me whether I can talk on a subject like this. I really agreed because last week I was engaging the neonatologist forum with an X-ray talk. I thought it is something like that. I never knew that it is a Zoom meeting. So it is said that it is meeting is for the house surgeons. Where are the house surgeons?
They have all joined, sir.
Most of
Around 60
those who are
60
joined are
people
house
have
surgeons.
Yeah, because I'm seeing only the senior faculty members. Because I'm going to talk briefly.
No, they have not opened the video.
No problem, no problem. I just wanted to, because I'm not used to this sort of classes. That's why. Okay, so today's topic for discussion is abdominal pain in children. It's as you all know, it's a very long topic. It is just not possible to cover the entire subject in a stipulated time of, say, 30 minutes or 35 minutes. I'll briefly cover this, the relevant points, that's all. Then I'll show you some examples, cases like that. In children, abdominal pain, it's a real pain for the child and the parents. And occasionally, he was rightly pointing out, it becomes a headache for the treating physician or the surgeon also. Luckily, abdominal pain, nearly 90% are very simple, self-limiting pain, or they can be managed conservatively. But there is a small percentage of them which are really life-threatening sometimes, or increases the morbidity. They are the conditions with red signals we can call, the serious ones among them. So the duty of the house surgeon or the treating physician is to identify which is which. That's what we are going to discuss today. Abdominal pain, as everybody knows, it's a very common complaint. A correct interpretation is challenging. So when you talk on abdominal pain, suppose I'm asking you a question. What is the commonest problem that you think? What is the commonest diagnosis that comes across your mind when we talk on abdominal pain? Everybody says appendicitis. That's not true. Appendicitis is one among the reasons for abdominal pain and probably the leading cause for surgical correction in abdominal pain with the needs surgical correction. Okay. Now, can you hear? Can you hear me?
Yes, sir. Yes, sir.
Yes.
Yeah, I'll continue then. Okay.
Yeah.
You have the absolute freedom to stop me at any moment. You need a clarification. I presume that it is still an interactive session. Okay. So, abdominal pain, appendicitis is just one among the many causes for abdominal pain. If you consider the various reasons for abdominal pain, can broadly be divided like this. Pain that arises in the abdomen, then pain developing elsewhere and getting referred to the abdomen. Then there are systemic diseases which can manifest in the abdomen, metabolic disorders like. Then, of course, neurogenic pain. See, whatever be the reason of the abdominal pain, there is a cause or etiology that we have to establish. Okay, we'll go into the details because one point the juniors should keep in mind, the abdominal pain need not arise in the abdomen. It could be referred from somewhere else. That point they should always keep in mind. Appendicitis is not the only diagnosis for acute abdomen. There are other reasons also. Right? These 2 points they should always keep in mind when they sort out the issue of abdominal pain. Okay, we'll see some of them. I don't want to go for a detailed theoretical discussion on this. Pain originating in the abdomen, it could be because of the irritation of the parietal peritoneum. Classical example, the bacterial or chemical, like perforated appendix. There's a tenderness, pain in the right iliac fossa. In say biliary peritonitis, when the bile leaks into the peritoneal cavity, all this can produce irritation. That is the pain in the peritoneal, parietal peritoneal irritation. Then comes the mechanical obstruction usually the intestinal obstructions presenting as abdominal pain, then biliary obstructions, stones or something like that, then ureteric colics, ureteric obstruction, extremely painful conditions. That means peritoneal irritation, mechanical obstruction, vascular reasons like thromboembolism or volvulus, then rupture of aneurysms, torsion, sickle cell crisis. Medical people, they should always keep this in mind. Then pain arising in the abdominal wall due to trauma or an infection, local infection. Then distension of capsules, hematoma under the liver, all those can manifest. Roughly, it is other than appendix, there are other reasons. They should know roughly, that's all. Then examples of pain referred from extra abdominal sources coming from thorax, like a basal pneumonia, upper GI, upper abdominal pain. Then cardiac pain, of course, in children, this may not be very relevant, but for older children, it should be there. From spine, radiculitis, referred pain. Of course, this one, the other condition, this is the one from external genitalia, torsion of testis. They classically present as hypogastric pain and vomiting. We'll come to some of the cases later on. So we have seen pain arising from the abdomen, then pain referred to the abdomen. All right. The other reasons, metabolic causes like lead poisoning, envenomation, all this can manifest as abdominal pain. Endogenous uremia, porphyria, diabetic ketoacidosis, urticaria. You people are in a better position to explain all these things. So neurogenic causes, herpes, when it heals, it will produce excruciating pain. Then functional pain, because if we find no reason, we usually call it idiopathic or functional, but there are some reasons explained these days by the gut-brain axis. We will not discuss in details on that. This is another entity. Now, coming finally to, now we know what are the reasons for the abdominal pain. Pain arising in the abdomen, referred, neurogenic, and other causes like. But with these possibilities in mind, I said to start with, nearly 90% of them are harmless. The child may be having severe pain, but with treatment, they respond very well. Now, what are the signs of what are the other features of, say, complicated one or the surgical problems, pain, which can be due to surgical reasons, surgical causes? See, these are the points you have to keep in mind. Abdominal pain, it could be, possibly it could be surgical. If the pain lasts for more than an hour, usually babies, they get colics, it comes off and on, disappears. But if the pain lasts for more than an hour, yeah, we have to suspect it could be something serious. Associated with bilious vomiting. It said that even if it is a single episode of bilious vomiting, it has to be treated as surgical unless ruled otherwise. So even if it's a single episode, you can suspect it could be something serious. But remember, 10% of the bilious vomiting is non-surgical. Okay. Then passing blood per rectum or in the vomitus, another red signal. Blood in the stools. Then patient rolling with pain. As we all know, children, they are not very dramatic in presenting their complaints. If they do this, they are having genuine complaint. They are not acting. They can't act. They are genuine. So they are not very dramatic in presenting complaints. Then patient waking up from sleep. That means again, it's a possibility of a surgical cause you have to entertain. Then pain shifting, that means pain arising in the umbilical region, gradually shifting the rightly across, is the classical example of an appendicitis, acute appendicitis. Then movements become painful. If you are having an inflamed bowel or an obstructed thing, or this one, movements are restricted, becomes painful. The patient or the baby looking sick and dehydrated. It could be something serious. So possibly a surgical reason. Now, these points you should entertain or keep in mind when you really examine a patient with abdominal pain. I'm not going to discuss the details of chronic pain. I'm talking only about the acute abdominal pain. Okay? Now, how to diagnose? This point is relevant. Now we know the various reasons for the abdominal pain. Then we know when to suspect a surgical problem. With these points, with keeping these points in mind, you start examining the patient. All right? Take a detailed history. History, just by seeing the age of the patient, you can get some clue. There are certain specific conditions which affect, say, infants, neonates, those things by the age alone. Then the duration reason, if the pain just comes and goes, or is it lasting for more than an hour or so, then associated with vomiting, bilious vomiting, then bowel and bladder habits. Urinary infection is a very common problem in children which can present as abdominal pain. Of course, constipation is a very leading cause for abdominal pain in children. So, detailed history, depending on, then you make a proper physical examination. Look for general examination, fever, febrile, jaundice, anemia, and dehydration. Just giving the tips only. You can take a detailed examination, then you know the various quadrants of the abdomen, depending on the complaint's location, and you know the anatomical structures around. Then you make the physical examination, come to a provisional diagnosis. The examination of abdomen is incomplete without examining the external genitalia. Again, the examination of abdomen is incomplete without examining the external genitalia. I'll show you some cases later on. Then, if possible, a rectal examination also. Then, in adolescent girls, especially when you take the history, the possibility of an ruptured ectopic, you should entertain. You cannot ask direct questions like that, but this possibility you must keep in mind. Rare possibility, of course, because if you miss it, it has a lot of medical legal implications. That's why. Then coming to confirming the diagnosis by doing the investigations. I'll give only the broad outline. What are the routine investigations we do? Blood examination, TCD, CSR, then CRP, of course, followed by ultrasound examination of the abdomen, because previously ultrasound examinations were not, now it is freely available. There used to be a time when we were practicing early, we had only the plain X-ray to help us. But this ultrasound is non-invasive. We get almost a reasonably good diagnosis. Of course, it is subjective, it depends on the sonologist. So you must be having sonologists whom you have some confidence. You can send the investigations to them and get a proper diagnosis. If the ultrasound fails, then you can ask for, say, for example, gas-filled abdomen, appendix is inflamed or not, we don't know. in that case, you can ask for a CT or MRI, depending on your clinical diagnosis. You can ask for the other investigations. Of course, I am not going into the final details of every investigations. Basically,
ಅಲ್ಲ ಮತ್ತೆ ಅದಾದ್ರೆ ಓಕೆ ನೋಡಪ್ಪ 2,500.
any question?
No, that unmute ಆಯ್ತಾ sir.
Okay,
continue.
okay. No, you can ask questions, no problem.
Yeah, somebody else.
This is supposed to be an interactive session. I will just finish. I am almost through to the other end.
Sir,
Okay.
ovarian torsion also is there, no?
Ovarian torsion. Friendly. That is, I have given you that list of things in that mentioned torsion. Rupture, ovarian torsion, tumor rupture is another thing. Aneurysmal rupture is another thing. I can show you some slides.
And how young sir have come across like ovarian torsion in a
Cyst
child?
we have come across, gangrenous cyst we have come across, is newborn, right from antenatal, right? It's from prenatal, antenatal, immediate postnatal, any age. We have seen all words because we have been seeing this for long now.
Sir, continue, sir.
Yeah. Is that okay? Now I'll show you an X-ray. Do you find anything here? Based on this, can you get a diagnosis? I'll give you the history. Like this patient presenting with fever, abdominal pain, and vomiting. The abdominal pain mainly periumbilical to start with. Now he is getting it in the right iliac fossa. I think the diagnosis must be straightforward, right? Examination, there is guarding and tenderness in the right iliac fossa. So what is your clinical diagnosis now? Acute appendicitis, okay. But what is the first investigation that you ask for then? An ultrasound can diagnose an acute appendicitis with perforation, okay. But this is a pre-ultrasound X-ray taken, old X-ray. You can see the date and all. This is very old.
Gas under the diaphragm.
Pardon?
Gas under the diaphragm.
Yeah, absolutely. But here it is not seen. That area is cut off, but there is no gas under the diaphragm. Any other point you expect from an X-ray? See, actually, when you see this X-ray, see the right iliac fossa, you can see some fluid, then some ileus, local ileus is there, some local ileus with the airflow level. The rest of the area almost gasless, right? Now, you see this line. Can you see that? Appreciate that? This is the properitoneal fat line. Here. Or this one, right? My cursor is on that. That is continuous. Whereas see this on the opposite side, it is broken. And see the scoliosis, protective scoliosis. When you get pain, you turn it to one side. So this X-ray gives everything, almost everything. And if you are careful, I agree that it's a poor quality X-ray. Plain X-ray can give you a diagnosis sometimes. See, there is a fecalith. See this? There's a fecalith. So there's a protective scoliosis, focal ileus with a fecalith and broken properitoneal line. If, as somebody rightly said, if gas under diaphragm is there, it is complete. So that's why even in the it's an old X-ray, I'm still keeping it because all these findings are there. So your diagnosis of acute appendicitis, this is X-ray is confirmed, but if you can, what are other investigations to do? Blood examination including CRP, will look for the rest of the developments there. What are the problems and how are you going to advise these children? How will you manage this? That's the question. You are clinically diagnosed acute appendicitis. Probably obstructive because there's a stone is there, fecal is there. This child needs emergency surgical management. Don't hesitate in referring it to the surgeon. At the earliest, they should reach the next higher center for further management. You must be familiar with the complications. What are the things? Of course, you should counsel them, the parents, properly. What are we going to do? What are the problems that we can face? Especially with the perforated appendix, in later life, they can get adhesive obstructions, intestinal obstructions, they can get. Wound infection is a possibility. But there are people who will not accept all these complications. So one has to be very, very careful and counsel them properly. Any question on this? I'm not going to the finer details of surgery or the other things. Shall I move? Okay. Can you see this appendix? It's a very long appendix. You can see the inflamed appendix, early
Yes, sir.
appendicitis. This is the right time to get it out. Very long appendix. Those days it was only open surgery. Nowadays nobody goes for this. They can do it with the laparoscopy. Laparoscopically you can remove this. Okay. Can you see the appendix there? So grossly dilated appendix. I have gone through a small incision. So because of the huge size of the appendix, I had to extend the incision to deliver the appendix. It's a perforated, grossly dilated appendix. That is the appendicular artery which I am trying to clamp. So it could be early appendicitis. Early appendicitis, say, depending on the sonological feature. Say, what is the normal size of the appendix? It is 4 to 6 mm. If anything above, say, 7.58 needs surgical correction, if that borderline enlargement, you can manage them conservatively with antibiotics. Nearly 50% of them will settle. They won't come again, but 50% will come back with the recurrence. So be careful. They need close follow-up when you plan conservative management. Any questions? Okay, well then we'll move to another condition which closely mimics appendicitis.
Sir, please discuss the antibiotic of choice in appendicitis from surgical side, sir.
That is we give them taxim, amikacin, metronidazole. With that, they usually settle.
Okay, sir.
If it is sulbactam, if this is in the having a gross collection, perforation, peritonitis is there, upper level we will go. Any other question?
There is another related question. Indications for surgical management in appendicitis.
Surgical management is I told you the size of the appendix. See, some people clinically they are having pain, rightly at first pain, tenderness, classical appendicitis. Okay, the sonologically the size is say 7 millimeter or 7.2 millimeter. What is the normal size expected? 4 to 6 is the normal size. If it is say 7 millimeter, what difference is it going to make? If the patient is having other symptoms like say persisting pain, vomiting, and all, we have to get it out. If the patient can be closely observed, they can be managed with antibiotics conservatively.
Sir, another question has come up is what is subacute appendicitis and what is the management?
Subacute appendicitis is a radiological diagnosis. This is mainly clinically you have to make a diagnosis. Is the patient symptomatic? Just for an abdominal pain, we will not. And see the size. If it is say less than 6 millimeter, there is no need to surgically intervene. Recurrent appendicitis is a diagnosis given by the radiologist. You have to clinically examine this patient properly and then plan the surgery. There is means a patient who had an acute appendicitis which was managed conservatively, and if he comes back with recurrence, then you have to get it out, because once we manage it conservatively and now it has failed, only 50% of the patients comes like that. Like that. Okay.
Sir, any role of CT abdomen if USG is not confirmatory, sir?
If it is inconclusive, you have to get a CT done. CT will tell you for sure.
Right,
Because
sir.
if it is really indicated, only we know we will do CT for children. No? Yeah, it can be. We really do it. Good question. Any other?
Any recent scoring system?
I'm not sure about it. I'm a very old man, not in the recent things. You call me in between like talk for talks like then I'll start reading.
They are
Okay.
asking if there any entity called subacute pancreatitis.
Subacute pancreatitis. Okay, there is a chronic pancreatitis, acute pancreatitis in between. We call it subacute or recurrent.
And for the
Pancreatitis?
conservative management, is it strict to keep the child NPO?
Yeah, for NPO you have to, because the child may be having vomiting. If the patient can accept oral feed, oral antibiotics is more than adequate. Any other?
Sir, if you are managing conservatively on antibiotics, sir, if after 7 days the child is not responsive to the antibiotics, sir, what is your take, sir, after?
No. They should be told. You have to report within, say, 48 hours if they are not responding to antibiotic. Because the borderline cases, we send them home with antibiotic, oral antibiotic. If they can accept feeds, that is no vomiting, means you can continue. If they are not responding within that 48 hours, they will definitely come back to you with the exaggerated symptoms.
Right, sir.
Any other?
No, sir.
Yeah, okay. Now, we'll move on to another condition which closely mimic appendicitis. That is the mesenteric adenitis. Previously, this diagnosis was not there. Now, with the advent of the introduction of sonology, people are picking up this pathology. If I get 10 cases of abdominal pain, 8 of them belong to this category. They are all referred as acute appendicitis. Because it is very difficult to differentiate between acute appendicitis and acute mesenteric adenitis. If the patient is having, see that complaints, abdominal pain, fever, vomiting, but they are usually having as an associated URI. An acute appendicitis patient can have URI. So how to differentiate? Not possible. Clinically, you will have the guarding, not guarding, the tenderness will be there in the right iliac fossa. In mesenteric adenitis, especially the ileocecal region where the Peyer's patches are there, the regional lymph nodes are there, they all get inflamed with the URI, upper respiratory infection. It's a reaction to. It could be either a viral or a bacterial adenitis. So they present with pain in the right iliac fossa. They may not be. They may not be having vomiting as we see in acute appendicitis. Then USG shows appendix within its normal range with the node size, if it is more than 8 mm, that is roughly. multiple nodes will be there. One of them will be having size this one. So it is the confirmation from USG. Treatment. There is no surgical intervention needed. You can give conservative management, including antipyretic. I mean, paracetamol is more than adequate, or just pain relief. Then tell them you don't need any surgery. This is the issue. That is the reassurance. That is what is I'm doing in the OPD. Out of 10 abdominal pains, 8 of them are mesenteric adenitis. They have gone from hospitals to hospital, various places, and finally they are being referred to the surgeon for opinion. I tell them your child doesn't need any surgical intervention, and this pain will last for say 2 to 3 weeks. He needs a lot of hydration. That's a lot of water the patient has to take. Then pain relief as and when required. Any question?
So for pain relief, usually paracetamol is given.
Paracetamol is enough. Paracetamol is enough because there is an upper respiratory infection associated. They will respond to, and saline nasal drops, paracetamol.
Sir, any role of antispasmodics in this?
Yeah, pain you can. What does it contain? Antispasmodics.
Or like dicyclomine?
Mechanism of action is almost the same like that. Na?
Okay, sir.
Right.
There's a
Correct.
question: is any antibiotic needed?
Yeah, antibiotic sometimes, because I said it could be viral, it could be bacterial. So within 1 or 2 days, if it is not responding, better to start some antibiotic. Mostly it is viral. Okay.
In case of antibiotics, which antibiotic will you prefer?
Usual cephalexin, mox, all these things will do. Or augmentin.
Okay.
Any indication for surgery?
In mesenteric adenitis, absolutely no. Because sometimes, rarely, I have not seen one. Can they go for abscess formation, which may need drainage. That is mostly it is viral infection, right? So viral infection, the secondary bacterial infection has to come. Then if you want to, you can classify this mesenteric adenitis as primary and secondary. Primary, I said it is from upper respiratory infection. Then secondary, if there's an inflammatory bowel disease. As a local drainage point, you can get it. Yeah.
And regarding feeds to the child, should we
A lot of liquid feeds, you can start. If there is no vomiting, anything, as usual, normal feeds you can start. Right?
And regarding the size of the nodes?
I said 8 mm, biggest. They will always report you like that. This is not based on the size. If the appendix is free, it is taken as mesenteric adenitis. We are actually doing the ultrasound to rule out an appendicitis. No further questions. Can I move on to the next one?
Yes, sir.
Okay. Small boy presenting with colicky abdominal pain, vomiting. Initially it was non-bilious. Finally it has become bilious. And simultaneously he was passing blood-stained mucus per rectum. Examination showed there's a vague mass in the umbilical region. Ultrasound confirmed. Yes, what is the confirmed diagnosis? 1-year-old boy, intussusception. Can you see the intussusception here in the picture? Very difficult. It's not a properly taken X-ray, even though it's a
Volvulus.
well, no, it's an intussusception. Now, what is an intussusception? It's an invagination of the one part of the bowel to the other. Usually, the proximal entering the distal. Why? That is the direction of the peristalsis. Any condition that increases peristaltic activity can result in intussusception. So if you go through the history of intussusception season, you get intussusception in the catarrhal season, 1 week, the other week is in the diarrheal season. Because both these conditions, if you see, they increases the bowel movements. Catarrhal season because of the mesenteric adenitis we were talking about, that can increase the peristaltic activity. So diarrhea, obviously. So it's the proximal bowel entering the distal bowel. See, my pointer is there. And this part, there is a proximal bowel which enters the distal bowel. That is the entry point. And it has traveled through this lung. Now, this point, you can see there is a difference in the color. Probably that segment is gangrenous. So, what is the management of intussusception? This is previously, so it is early, say 90s, we were all doing a laparotomy, either reduction or resection. That was the treatment. Medical college, we were operating roughly around 400 cases per year. Now nobody operates for intussusception. They can easily be reduced using the ultrasound guidance, hydrostatic reduction or a pneumostatic reduction using air or saline. So that is how this case is managed nowadays. But this is an ileal intussusception. But your enema reduction is not possible here. That's why they failed hydrostatically to reduce it. That's where I had to intervene, do a laparotomy. I'm trying to reduce it from here. See that? This end is still stuck there. It is not getting reduced. So you can't expect the serologist to do it. Even after opening up, I'm finding it difficult. So finally, I opened and found what is that structure? Can you identify? On the anti-mesenteric border of the bowel, clear. That's it. Meckel's diverticulum. It was a Meckel's diverticulum which got invaginated into the bowel that was leading as a lead point, increasing the peristaltic activity, producing an intussusception. So there is a reason. There is a reason for this intussusception. We call it secondary intussusception. Primary means there are no obvious reason seen. Simply because of the increased peristaltic activity, the proximal bowel enters the distal one. Whereas in cases like, say, Meckel's diverticulum, polyps, lymphomas, all this can produce intussusception. That is known as the secondary intussusceptions. So this had to be removed, resected, and anastomosed. What are the other complications of this Meckel's diverticulum other than producing an intestinal obstruction like this? It is notorious for bleeding. Why? It can perforate. Why? It contains ectopic, gastric, and pancreatic mucosa. Ectopic tissue, the gastric tissue which produces acid, it can produce perforation in the bowel. So when you resect a segment of the intestine along with, and then anastomose. So intussusception usual age group is below 1 year. When we start the weaning, that's when it starts regularly. Any question? I'm not going to the final details of it. Okay, shall I move? it's a newborn baby presenting with bilious vomiting. Bilious vomiting means we said it is to be taken seriously. So repeated bilious vomiting, and at the same time, baby was passing stools. If that is the case, what is your inference? Baby is vomiting and at the same time passing stools. It suggests an incomplete obstruction, probably incomplete duodenal obstruction. So what are the reasons for incomplete duodenal obstruction? The commonest cause for incomplete duodenal obstruction is malrotation. It's a complicated issue, so seniors will understand. For the house surgeons and juniors, the normal rotation of the bowel, what are the normal positions of these structures, you must have a rough idea. So to rule out a malrotation, because they present with the intestinal obstruction, so we have taken a plain X-ray. Anything special here? The plain X-ray, not diagnostic of malrotation, but you can see something special. The large intestine is confined to one side, left side, and see the small intestine to the opposite side. That is probably an incomplete rotation of the colon. I'm not going to the final details of bowel rotation. It's a complicated issue and difficult to follow also. Okay, to confirm the diagnosis, we have done a barium meal because it is producing a duodenal obstruction. In malrotation, there are bands which cross the duodenum, known as the Ladd's bands, which obstruct the duodenum. That's why they produce incomplete obstruction. So to see the obstruction in the duodenum, we have done a barium study. See that? The duodenum is dilated, stomach is dilated. The intestine, the large intestine is still on that side. Say another view. Yet another view. Now finally it's a magnified version. You can see the stomach is dilated. The duodenum is dilated, but see it beaks, it becomes pointed. It is beaking. What happens if the tube you twist like that, it narrows down. The lumen is, that's called a beaking. If you see beaking in a barium study, it's a danger signal. It suggests volvulus. So this, if malrotation develops a volvulus, the entire midgut undergoes twisting or volvulus. On the fulcrum, the superior mesenteric artery acting as the fulcrum, the whole thing twists around the superior mesenteric artery, and this is what happens. Can you appreciate that? It's a very nice picture, rare picture, not commonly seen. Luckily for this patient, it is not gangrenous. So another view. So what we have to do is derotate and make a broad mesentery. That means the ileocecal junction is taken from here and taken to the left hypochondrium, and the duodenum is straightened and it comes on the right side. Otherwise, we are recreating a broad base for the mesentery to prevent further volvulus formation. Okay, it's a tough topic, but I just wanted to show you it's an emergency. Yeah, it's salvageable. See, this child was very, very lucky. In spite of having a midgut volvulus, we could save that child without any problem. Any question on that? If no question, Probably,
Sir, if the intestine was already gangrenous, would there be any other symptoms?
yeah, because the child will be very sick. You want to see? See this child? This was not a lucky child. The reason for volvulus is something different because it was a duplication of the bowel duplication system in the bowel. On that, the whole intestine has rotated. They came late. The entire midgut, they lost the midgut baby. So this has to be resected along with this, and the viable segment has to be anastomosed. So with a sequelae of short bowel syndrome, short bowel, because this is if they this child actually survived, but he lost most of its intestines. If they're perforate, they can go for septicemia, but even that's very, very dangerous condition. Volvulus, clinically. To diagnose it, we can use the ultrasound, the superior mesenteric artery position, arteriovenous position, and all. But barium male is the ideal investigation. Any question?
No, sir.
No. Okay. Then constipation. I'll tell you a story. Now you are all waiting your dinner, right? So I remember attending a pediatric gastro conference. So it was a pre-lunch session, and the speaker was talking on a chronic abdominal pain. He kept on narrating all the causes of chronic abdominal pain. Then everybody got bored. then came an announcement. The lunch will be ready only after the next paper, next talk. So what is the next talk? It is the chronic constipation is the next talk. So I was watching the facial expression of the crowd. I think you people are all in that position now. I won't stand between you and your dinner. I will finish it up quickly, right? Constipation, another reason for the abdominal pain. Why? There is a regular bowel movement. Everyone is happy. Parents are happy, child is happy. And as it's for us also, it is we are all happy when we have a regular bowel movement. But the constipation can produce back pressure effect, logging, gas toilets, severe colic. But when we discuss about the history, we said bowel and bladder habits. That should be a routine. So if there is a history of constipation, a rectal examination will confirm the diagnosis. Okay, there are other differential diagnoses. Of course, we are going to discuss that briefly, not in detail. So meconium retention is one reason. Newborn constipation, meconium retention. What are the differential diagnoses for meconium retention? Mainly, the patient should be having an anal opening. Okay, anorectal anomaly. Then comes the Hirschsprung's disease. The diagnosis of Hirschsprung's disease is based on if a full-term baby with normal anal opening, if he or she fails to pass meconium within the first 24 hours, it is taken Hirschsprung's disease unless proved otherwise. That's the definition of Hirschsprung's disease in newborn. Full-term, normally born. Full-term means it is not a preterm baby. Preterms can have retention meconium. Normally born, the second stage is not prolonged. So there is no hypoxemic injury or hypoxemic bowel retentions. So with patent anal opening, anorectal opening anomaly is ruled out. If he or she fails to pass meconium within the first 24 hours, it is Hirschsprung's disease unless proved otherwise. I will give you another scenario. A baby with hypothyroidism. Full-term, normally born, patent anal opening, but that patient may not pass meconium. So that is the immediate differential diagnosis for meconium retention of Hirschsprung's disease, hypothyroidism. Okay. Then comes another chronic constipation. We'll say something on that. Then we'll see some pictures of her. This is a newborn baby presenting with failure to pass meconium. Anybody want to comment on this? We have taken an X-ray.
Absence of
suspecting
rectal,
Hirschsprung disease.
absence of rectal gas.
No, the rectal gas is very much there. Where is the cursor? Can you see? See, that is the rectal gas. Can you see that? The pointer is there. That's the rectal gas.
Okay, sir.
Huh? Okay, then any other possibility? Why? The X-ray of the knee joint is included. See? Anything missing there? The first epiphysis to appear is the lower femoral epiphysis, which is absent. Do you want to connect it with some other diagnosis? Hypothyroidism. Because of your routine screening, nobody will miss hypothyroidism. This is pre-screening era. See the plain X-ray, we were suspecting a Hirschsprung's disease, but seeing the rectal gas, it is usually absent in, say, suspected Hirschsprung. See this one, for example, same history. The patient has full-time baby, failed to pass meconium within the first 24 hours. See, the rectal gas is absent. The femoral epiphysis is present. Features of intestinal obstruction. So how do you confirm Hirschsprung's disease?
Rectal biopsy.
No, that's an invasive procedure. Other simple things. Yeah, that's gold standard, rectal biopsy, agree. Barium enema. Because we want to demonstrate see that the distal segment where the distalmost part of the colon is aganglionic. So that area will be narrow. See that? It's a narrow segment. Then there comes a gradual transition segment and dilated segment. This is the typical barium enema, which suggests a Hirschsprung's disease or congenital aganglionosis. Treatment and other details we will not discuss now. Initial deflating colostomy done, definitely pull through is the management. So meconium retention, one must suspect Hirschsprung's disease, anorectal anomaly, and hypothyroidism. This is a common diagnosis. There are rare diagnoses like the mucoviscidosis or cystic fibrosis, which is not very common in our part of the country. Then preterm babies, they have retention of meconium. Then sepsis, infection, because all these are affecting the ganglion cell function, either with toxemia or hypoxemia. So that's how. So Hirschsprung's disease, if it is left untreated, what will happen? Because of the chronic retention of motion, they can develop enterocolitis, which could be deadly sometimes. They can produce very severe sepsis. Enterocolitis is a sequelae. Any question? Okay, I know it's an incomplete discussion, but we cannot go into the further details of this. Just wanted to show you there is a condition like this, and this is what we do. As somebody has rightly pointed out, there are other investigations other than barium enema, rectal biopsy, with histochemistry. That is acetylcholinesterase increase, that is demonstrated in histochemistry. Immunohistochemistry, we call it. Then comes the anorectal manometry. Manometry based on the normal defecation reflex. I'm not going to ask those questions, but you should keep these things in mind. Anorectal manometry, non-invasive. Rectal biopsy is under GA or it's an invasive procedure with some complication. No further questions. Shall I move?
They have asked regarding the difference between barium meal and follow-through.
Barium meal follow-through, how long it takes to reach the area? Your suspicion is constipation. You are suspecting Hirschsprung's disease. So from here, unnecessarily you are giving barium in a patient with intestinal obstruction. What will happen? Barium will clog and it will further aggravate the intestinal obstruction features. So this is the ideal one. See, only lower area is examined. Whatever needed is pushed. It should be ideally done under fluoroscopy. So whenever you get a narrow segment and a dilated segment, stop it. There's no further need for further injections. Okay. it is otherwise telling you indirectly. See, this is the aganglionic segment. The narrow area is aganglionic segment. This is the normally ganglionated segment. That will help you to place the colostomy. The colostomy should be in the normally ganglionated segment of the colon. Okay. Another baby presenting with bilious vomiting and abdominal distension. Suspecting intestinal obstruction, malrotation, like they have taken an X-ray and referred to us. What is it? Anything you can see here? Anybody want to comment? No? Okay, see this X-ray. There are features of intestinal obstruction. At the same time, you see the scrotal sac. See the scrotal sac? It is containing the bowel. So it's an obstructed inguinal hernia. Just to tell you the importance of examination of the external genitalia. That's what I said. Abdominal examination is incomplete without examination of the external genitalia. So this doctor missed the diagnosis, unnecessarily exposed the child to an X-ray. Simple clinical examination does settle this issue. So we had done a reduction of this hernia and herniatomy. Patient is okay. So that's the importance of examination of the external genitalia. See, in spite of having an X-ray, people are finding it difficult to identify. Next. One of the reasons for abdominal pain, I said, it's urinary infection, urinary tract infection in children. Very, very common entity, especially in girls and boys. It is almost equal. But if I see 100 patients, 30 of them, 30% of them are urological problems. So that is the incidence of urology and urinary tract infections. And it's urinary infection occurs because of some congenital anomalies of the genitourinary tract or refluxing of urine back into the system, then some obstructive lesions, then immunocompromised children, neurogenic bladder, all these are the reasons for repeated urinary infection. This X-ray is an MCU, mixed-routine cystourethrogram, done as the part of workup of a urinary tract infection. What do you find here? What do you see? That is the bladder. That is the posterior urethra. You see, it's a grossly dilated posterior urethra, almost like a spinning top. So that's a classical posterior urethral valve in a boy. See that the distal urethra is narrow, like this. So that is a posterior urethra, grossly dilated urethra. That's a gross reflexing into the kidneys. You can see the kidney. So it's a grade 5 reflux. Grade 5. That means it's an obstructive uropathy posterior urethral valve with the gross reflex on one side, and it is reaching almost to the copical level. That means grade 5 reflex. That means probably this kidney is dysplastic to start with. So treatment is you relieve the obstruction, then okay, the details we are not going to do. This is control the urinary infection. Next, another MCU, same patient presenting with urinary tract infection. This MCU, what is special? You have seen this one. There is clear X-ray. You can see the bladder, you can see the posterior urethra. There is reflex. But this one, it is equally, the colon is loaded. The radiologist will say the preparation is not adequate. See, the colon is loaded. But see something special about the bladder. There is a trabeculated bladder. This is the classical description is the neurogenic bladder, the Christmas tree bladder. You see in neurogenic bladder. They can manifest with recurrent urinary infection, reflux, all those problems. In neurogenic bladder, you get, there is constipation also, because the nerve supply, which supplies the bladder and defecation reflex, almost the same now. So, see, this is the reason for that. In this child, we have taken a lateral view, which shows, see, the sacrum is absent. That means the S23 segment, which supplies the bladder and the rectum, which is absent. Classical neurogenic bladder. All right. Another patient with urinary infection, recurrent urinary infection. See the MCU? Bilateral gross reflux. There is no bladder. Whatever you put in, see that there is no bladder. Whatever you put in, it goes into the kidneys on either side. It's a very difficult situation to manage. If there's a gross reflux, what we do is we re-implant it to prevent the reflux. But if there is no bladder, management is tough, difficult. Because one of the reasons for urinary infection, I just wanted to show you. We have seen the obstruction, we have seen the reflux, we have seen the neurogenic bladder. Patient presenting with pain and swelling in the left hemiscrota of 1 day duration. Finding is, you can see this swollen, that half. See, this is a normal, this is the swollen side of this one. What are the differential diagnoses for acute scrotum? Acute painful enlargement of the scrotum, we call it acute scrotum. Again, what are the differential diagnoses?
Torsion.
Torsion, of course, you must, that should be the first diagnosis. Priority should be given to torsion. Then, epididymoitis is another one, infection. Then, local infection, there is scrotal, idiopathic scrotal edema is another condition, cellular scrotum, all this can. But see the redness, obviously suggesting infection. So we had to do an ultrasound, especially you call it, the specific ultrasound examination is color Doppler ultrasound. We are worried about the vascularity of the testis when you suspect a torsion. So if the patient reports within the first 4 to 6 hours, we may be able to salvage the testis. If it is more than 6 hours with acute torsion, very difficult. I'll show you the next film. See, the exploration showed totally gangrenous testis. What is the treatment? For this gangrenous testis, you can untwist it and see whether it improves, the vascularity improves. Unlikely. You can apply some hot mops and see whether the vascularity improves. No. It has to be removed. That is orchidectomy. Any danger of doing an orchidectomy? Because the etiology of torsion being bilateral, we should prevent torsion on the opposite side by fixing the testis. We call it orchidectomy on the affected side of gangrene and orchiopexy of the normal side to prevent the same thing happening on the opposite side. That point you should always keep in mind and should explain it to the parents. Then, any question? Because that's the importance of examining the external genitalia. The abdominal pain, usually they present. With acute torsion, it is referred to the lower abdomen as hypogastric pain, vomiting. So the early presentation may be as a referred pain. So if you examine it early enough and identify it, you can salvage the testis.
Management of epididymoitis.
Depending, it's an antibiotic. You can take, or how the epididymoitis comes, probably from systemic infection or ascending infection, reflux of urine. So urine culture you should do, and based on that you can change the antibiotic, but straight away you can start on augmentin. Amoxicillin will be effective antibiotic. Yeah. Any other question?
ഒരു സൈഡ് എടുക്കുന്നതിൽ ഒരു മിസ്റ്റേക്ക് ഉണ്ട്, അതായി നോക്കുന്നത്. അല്ല പഠിക്കാനായിട്ട് ഇപ്പോഴല്ല മോളെ, നോക്കട്ടെ, തിരിഞ്ഞു വന്നു ഒരു മിനിറ്റ് തിരിഞ്ഞു.
Yeah. So any question? So should always remember the etiology is bilateral. That should be explained to the parents, and the opposite side should be fixed if you have to remove the testis. Orchidectomy here and orchiopexy on the normal side. The reason is etiology of torsion bilateral. That point you should always keep in mind. Then few reasons for this one. For diagnosis.
HSP.
HSP. Anybody can diagnose HSP. But how come will they present as abdominal pain? What to do with abdominal pain? It's an allergic vasculitis. It can affect any area of your body. So it can manifest as hematuria. It can manifest as hematochezia. So if the bleeding occurs in the mucosa of the bowel, there it can bleed. It can produce edema, pain, intussusception, gangrene. Everything is possible. The dangerous situation always taken for granted. Right. HSP. Then some points on chronic constipation, which can usually manifest as abdominal pain. How do you manage that? Chronic constipation. Usually it follows a painful event, say a fissure in the ano, or some passing a hard stool producing pain. The baby refuses to pass motion afterwards. Every time he or she gets a defecation reflex, they will deliberately hold it. Not passing stool, it remains there, it becomes dehydrated, it becomes hard stool, that cycle goes on. So chronic constipation is a very common topic, common problem that come to you with the abdominal pain. How do you manage that? That itself is a big topic, but briefly, laxatives, round the clock laxation. The hard stool has to go. The hard stool sitting in the rectum has to go. Then it should be a long-term process. You must give laxatives sufficient doses adequately for minimum period of 6 months. How? You give it for 1 month, reassess. If the patient is not responding, if he starts sitting to pass stool, that means half of your treatment is over. Then gradually you can reduce that dose by tapering it, not stop it abruptly. Gradually taper the dose and finally stop it. So there is part of toilet training is part of the management of chronic constipation. Laxatives, suppositories, plenty of oral fluids, then counseling, because the patient will not, because I know patients who are taking medications for the past 6 months, 1 year, 2 years like that. But generally 99% of them they settle with proper treatment. It's a very common condition which can manifest as abdominal pain because of the gas colic. And when you give laxatives, the lactases, they act by absorbing water into the, attracting water into the lumen, liquefying the stool. That they increases peristaltic activity. That itself can produce abdominal pain. The laxatives itself can sometimes produce abdominal pain. Okay. So, shall I stop here? Thank you. Thank you for your patient listening. You are now free. You can ask questions. We'll discuss if it is possible.
So one last question, sir. Any electrolyte abnormalities which is caused by lactulose, sir, on a long-term basis, sir?
I don't think so. I don't think.
For giving, sir, 3 months, 6 months in a toddler or infant, sir, it is
Those are just always. It will not, because you give a lot of water along.
okay, sir.
Sir, should we do anything for the mesenteric lymphadenitis? Very commonly, children are coming with abdominal pain
which is not at all subsiding. So
It's a big nuisance. That is what the last point I said, reassurance. Tell them this is what your child is suffering from. It will take minimum 3 weeks to settle. Okay. So
what is the best laxative?
Laxatives, I should not say that. I am giving smooth.
PG, whatever the PG.
PG, okay. Some people give it. It's equally good. Equally effective.
Ayurvedic medicine, that is Anasof.
I'm not familiar with.
In my opinion, for the mesenteric adenitis, I used to give them a dietary advice. Don't use heavy food, like use only weighted food. Avoid and that oily foods. Used to get good results for 2 weeks.
Anyway, there's no specific treatment for that condition. Anything that works is good. You can make a paper on that. Because it's excruciating pain, very, very painful condition there. And parents are not at all happy with our treatments. Because you have to teach them, this is the condition, it will take time. That point you have to drill into their brain. You have to tell them. That's what I am doing daily because I am getting a lot of them. You people are very happy to refer these patients to the surgeon. So I have to tackle them daily. Somehow they are all doing well. Probably going to another hospital, probably. I don't know.
Thank you, Akbar sir, for that crisp and lucid talk, sir. Thank you so much for being with us today.
Because I couldn't prepare only this much. I didn't know that it's a webinar like this.
Yeah, it is okay, sir.
I would like to talk openly. If you have any open discussion, I'm very happy to take part.
If anyone
Okay,
have any queries, please unmute and ask. Sir will be very. Dr. Nisha, if there are no more questions, we can wind up.
So, respected seniors and residents, now on behalf of the TIPS, I thank Akbar sir for that extensive and elaborate session. And sir took a lot of pains to interact in between the sessions. Sir was replying to all the chat questions and all. So thank you, sir, once again. And I also thank the IEP in this session. And my chairperson, Dr. Johnny students, the medical college faculty. Thank you all. Good night. Shall we close?
Thank you, sir.
Thank you.
Good night.